The disease is increasingly managed as a chronic condition rather than a diagnosis with an immediate terminal-like outcome. Particularly with earlier, more effective and sustained treatment options, we can make this disease a very chronic, long-term, livable condition. I want to make sure that patients are aware that this is not a death sentence, right? This is something that patients can live with for the long term.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between.
Welcome to the ONS podcast. I'm your host, Lenise Taylor, Oncology Clinical Specialist at ONS. And today we're talking with Ann McNeill, nurse practitioner at the John Theurer Cancer Center at Jersey Shore University Medical Center in Neptune, New Jersey, about long-term multiple myeloma considerations for oncology nurses. This episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation linked in the notes. Thanks for joining us again today, Ann.
It's my pleasure to be here.
In previous episodes, we talked about treatments for multiple myeloma, so let's pick up from there. Understanding that myeloma is an incurable hematologic malignancy, what are the guidelines for treatment goals?
Yes, we do consider myeloma an incurable hematologic malignancy, even though we have had improvements in survival. But I guess just like for any malignancy, our goals are to maximize survival. We want to, of course, eliminate as many myeloma cells as we possibly can. And subsequently, we want to improve the quality of life for these patients in the long term. So those are basically our treatment goals. That's what we think of when we're treating patients actually all throughout their treatment journey.
What are some of the late effects of treatment and how can they be managed?
We do have several late effects of our treatment options, and how can they be managed is a good question. I'm just going to go through a couple of them and the possible ways that we can manage them. So one of the late effects of treatment is peripheral neuropathy. The second one is persistent fatigue. We can also see bone damage. We can see kidney dysfunction. And last but not least, we can see an increased risk of infection. Sometimes we have to adjust medication dosages. Sometimes we have to give additional medications, for instance, to mitigate infection risk. Sometimes we give prophylactic antimicrobials. Sometimes we use physical therapy and lifestyle modifications, such as exercise and nutrition, to help with persistent fatigue and even to help manage bone damage. So again, peripheral neuropathy, usually we can try to do things like physical therapy. We can give some medications to offset the discomfort that's associated with peripheral neuropathy. For persistent fatigue, that would be the lifestyle modifications, such as exercise and good nutrition. Bone damage, again, we want to do some physical therapy and gentle exercising and really keeping the mobility as best as we can throughout their journey. Increased risk of infection, of course, we have to try to mitigate that by antimicrobial prophylaxis and telling patients what to report and when, so that we can jump on infections as soon as we think they are occurring rather than at later stages when it could be more problematic.
I can definitely see where some of those can play into the quality of life issues that you talked about after my first question. So how can these late effects differ based on the treatment modality an individual received?
So the first thing I mentioned from your previous question was peripheral neuropathy, and that was most likely due to a drug called bortezomib. And it's still used as a treatment option for patients with myeloma. And we have other medications that also have a small increase in the risk of peripheral neuropathy. Nerve damage from the bortezomib is something that we have seen in the past and we continue to see if patients are using that drug. I guess what I mentioned before is very important that patients report peripheral neuropathy as soon as it occurs so we can make our adjustments in medication dosages or in the treatment dosing schedule to kind of mitigate this. We can see bone damage from lytic lesions, and that could be from disease, usually. So for that kind of issue, we usually will get a pain management team on board. We will also use bone strengthening agents like bisphosphonates or even denosumab. I think it's important that patients become aware of gentle weight-bearing exercise and some physical therapy. Some of the other later effects are definitely the infection susceptibility, especially with the new immunotherapies that we have now, Lenise. We have a lot of BiTEs or bispecific T cell engagers that we're using, which can weaken the immune system. For that, how do we manage that? Again, we can use antimicrobial prophylaxis, giving medications to lessen the risk of things like shingles or PJP or even some bacterial infections. We can also give appropriate vaccines. And another thing we can do for that is administer IVIG, which is an immune system booster. And where I am, we tend to give this on a monthly basis during the winter months, especially when it's cold and flu season, especially to reduce the risk of patients getting these upper respiratory infections, which are more likely to occur during the winter. So we try to give it monthly for those people who meet the criteria, just to kind of try to help them out from an immune perspective. I think also fatigue, the late effect of treatment. So patients, sometimes they're done with their treatment for a while. They might have gotten transplant. They're in a treatment-free interval for a while, and they still complain of persistent tiredness, maybe memory issues, all related to treatment. I guess memory issues, we call it the, in quotes, brain fog, right? Patients complain of brain fog. To offset this, we always recommend good sleep. And that sometimes is something our patients can't get a handle on. So we try to get them some exercises, sometimes some medication, but some good things to do to kind of get them in a good sleep mode, good nutrition. We do have dietitians on board frequently that will see them and give them good advice about their nutrition. Exercise can also help offset fatigue. Another aspect of a late effect of treatment could be kidney damage. That could be long-term from disease or from treatment. You have to understand that some of our treatment options are renally dosed. So we want to be very careful of the treatment option we choose for our myeloma patients. We have to be mindful of the kidney function of the patients and give the appropriate dose of the medication. So how do we monitor this? Of course, we're doing lab work regularly, making sure patients are adequately hydrated. Of course, patients who are volume sensitive, we're going to be a little bit different with our fluid recommendations. And of course, we're always trying to avoid nephrotoxic drugs or agents in these patients. So that's kind of important.
Wow, that's a list. And that is something to think about. You're living a much longer time with this disease and going through multiple different lines of treatment. And to have to keep layering these things on and looking for those side effects and managing them is important.
I think that patients and oncology nurses will be able to attest to this. I think fatigue is certainly something that patients will always complain about, regardless of whether they're on active treatment, whether they're on observation, post-transplant, pre-transplant, or whatever it may be. I mean, fatigue seems to be something that is persistent in their life and very difficult to manage it. I think they have to really kind of determine what's going to, and of course we have to rule out real reasons for fatigue, right? Like anemia and things like that. But I think that patients need to have some lifestyle changes to kind of help offset this persistent fatigue and even the brain fog that comes with being on treatments for any kind of malignancy.
Exactly. I know one of the points that somebody told me early on in my career that I took to heart when I was doing my patient education was for people to kind of take a diary, make a diary of what their high and low points were during the day, and then to tailor their activities based on that. And I think that's really important. You may end up, if you like going for walks and you normally went first thing in the morning and all of a sudden you're not a morning person, then turn it into an afternoon walk, something like that.
Absolutely. I totally agree. We always make patients make the best of their good days and bad days. And actually, like you said, the good times of the day versus the weaker times of the day.
So what might disease progression look like in someone who has had multiple prior lines of therapy?
In 2026, many of our myeloma patients have had multiple lines of therapy. We've come a long way with different treatment options for myeloma patients. So it is very typical for our patients along their journey to have received several lines of therapy. I think it's important to realize that the cells acquire new mutations, making them more resistant to these further subsequent lines of therapy. So what do we see? We see quicker, more aggressive relapses in those patients with multiple prior lines of therapy. We can see an increase in the CRAB symptoms, which is the calcium elevations, the renal dysfunction, profound anemia, and even bone disease. We can see a rapid rise in the M protein in the labs, or even a very rapid rise in the involved light chain in that serum-free light chain assay. So it's important to monitor these labs And I think it's really important to monitor patients' labs, especially if they've had multiple prior lines of therapy, because our labs can be the first indication of patients who are relapsing before they even feel sick. And especially somebody with multiple lines of therapy, we don't want them to damage their organs. So looking at these labs frequently, we can kind of jump on this relapse right away before they actually feel, in quotes, sick. And even sometimes with more aggressive relapses, we can see soft tissue plasmacytomas. So patients with multiple lines of therapy, and I've seen patients with literally 15 to 20 prior lines of therapy, they can develop these soft tissue palpable lumps or tumors that can appear. We can also see, although rare, we have seen CNS involvement with relapse disease, so central nervous system involvement, or what's called leptomeningeal disease. And we've also seen, again, not too common, but we can see this, and nurses should be aware that we can see plasma cell leukemia as an aggressive form of relapse, which means that there are now circulating plasma cells in the peripheral blood, which is a very aggressive form of the plasma cell disorder. So again, we can just see these rapid M spike elevations and involved free light chain assay abnormalities. But it's important to remember that despite these numbers being normal or even stable, we can see these other things that can happen to patients who are relapsing in an aggressive state, like the soft tissue plasmacytoma, plasma cell leukemia, and even CNS disease.
I hadn't thought of those. You mentioned a little bit about wanting to watch labs. So if you've got somebody who's in, as you termed it, a treatment-free time period, how frequently would you be expecting to check labs?
If somebody is post-transplant, they're fairly new in their journey. They've had induction therapy. They're still technically in their first line of therapy. They had a transplant early on and they choose not to get maintenance therapy. I would probably do it every couple of months, every 2 to 3 months, I would check their labs. However, somebody who has had multiple lines of therapy, usually they are on treatment, some kind of treatment. So we check the labs monthly. And even if for some reason they're on a drug holiday, for whatever reason, we would be very careful to not let them slip away and go longer than like a month without checking some kind of myeloma assessment. It doesn't have to be the whole myeloma panel, but just doing like even a serum immunoglobulin level or a serum protein electrophoresis or even a serum free light chain assay, some method to determine the status of their disease at that time.
That's good to know. So, Anne, what are some key aspects of a survivorship plan for individuals living with multiple myeloma?
All oncology nurses, they're all focusing on these survivorship plans now. And I think that's a great thing when you think about a diagnosis of cancer and then talking about a survivorship plan, even for patients with solid tumor malignancies. I think that's wonderful because it means these patients are living a longer time. So I think we still look at long-term health maintenance guidelines. So depending on the patient's gender and their age, we still follow the guidelines for long-term health maintenance. For instance, we are still recommending colonoscopies, mammographies, PSA levels, still recommending cholesterol screenings, all of the routine screenings that are recommended for a patient, like I said, depending on their gender. We are always continuously monitoring for disease recurrence. And we just mentioned that before about their labs. We are always doing some kind of continuous monitoring for disease recurrence. And sometimes that's just blood work. And sometimes it's even their 24-hour urine samples. We're always continuing to manage their bone and kidney health. And that is also with labs and sometimes with imaging studies. If somebody has all of a sudden a new pain, we may need x-rays, we may need CAT scans, we may even need MRIs, but that's also something that we are doing in the survivorship mode. And I think preventing infection is always going to be something we're absolutely on the forefront in our survivorship plan with myeloma. I mean, myeloma is an immune system malignancy. The treatments that we have given patients can sometimes, especially in later line therapies, further compromise the immune system. So we're always looking to prevent serious infection. And of course, we can't not include addressing the psychosocial, the financial, and the physical rehab needs. We're always looking at the patient as a whole, assessing them frequently from a psychosocial perspective, financial perspective, and do they need additional physical therapy? So our team and most of the cancer centers I'm aware of have teams to assess this on a regular basis with our patients.
This is a disease that people are living with for longer, as we've mentioned multiple times. How can the oncology nurse help people navigate their journey with multiple myeloma, including what we talked about, frequency of labs and follow-up visits in the midst of trying to have as normal of life as possible?
I think that nurses are crucial in this regard. And by that, I'm going to tell you a little story. And this has happened to me more than once, unfortunately. Patients get treatment, especially induction therapy. They may or may not get transplant. They may have been on a very minor maintenance schedule, depending on their age, and they feel really well. And then they decide not to return for their follow-up because they feel so good. I think nurses are critical in the communication aspect of the patient provider aspect. So nurses are really the key means of communication. I mean, listen, the providers are absolutely important, the physicians, the nurse practitioners, and every other member of the team. But I think the nurses have a really special rapport with patients. They're the ones usually providing the education on the treatment regimens. They're managing the toxicity profiles. They're doing all the coordination of care between visits. So they are really going to be the ones telling the patient, hey, you're going to feel good and that's a wonderful thing, but you still need to come once a month or once every 6 weeks or once every 2 months for your labs. And you do have to bring your 24-hour urine. We're going to make sure that your disease is still under control. So I think that it's important for nurses to explain to patients that we want to tell a patient that the disease is kind of coming back. It's kind of rearing its ugly head, if you want to say, right? We don't want them to come back to us when they're really sick. We want to tell them, hey, your labs look a little concerning. We want to repeat them like in such a time frame, and then we might have to start our treatment while you're still feeling well and have the best chance of doing well with treatment and doing well with getting your disease back under control, as opposed to you staying away from us and coming back when you're having new bone pain or you're hypercalcemic and having symptoms related to that condition, with that kind of thing. So I think that nurses really play a critical role just based on communication that they have with the patients and the great rapport they have with patients.
And that is such an excellent point, because when you have many other malignancies, they finish with their treatment and then we say, okay, we'll see you back in 3 months because we're expecting them to be fine during that time. But you've pointed out how this can very quietly just kind of come back without people knowing. And so it's very important to kind of shift our way of thinking to be more of a, let's be very proactive and keep a little bit closer eye on you so that we can make sure that you're well.
Right. We don't want to miss that window, Lenise. We don't want to miss that window where we can see the labs behaving badly. And we know, for instance, we might even have to tell the patient, well, the labs look a little concerning. So instead of you coming back in 2 months for new labs, we want you to come back in a month. So we just want to really keep really up on these labs, So that's why I think it's really important that patients, even if they feel well, they return at the regularly scheduled time that we want them to return. And I can't tell you how many stories I have where patients just fall off the radar and you're like, oh my God, they're coming into the clinic and I haven't seen them in 9 months and now they're not feeling well and they decided to call the office. So we want to try to avoid that. So I think good communication is key in that regard.
Talked a lot about some of the long-term side effects and ways of managing those, but what are some of the other physical challenges patients living with multiple myeloma may experience? You talked a little bit about renal health, bone pain, sexual dysfunction. Any thoughts on how to manage those?
I think it's important to realize that the average age for myeloma patient at diagnosis is about 69. I mean, we do see younger patients and we see older patients, but we are going to see patients with some comorbidities already present in a lot of our patients. So they may already have some renal issues, maybe from diabetes or hypertension. They may have some bone issues just from being arthritic or whatever. So let's talk about severe bone pain, right? The issue with severe bone pain is that we want to make sure that patients are not at risk of pathologic fractures or at an increase of having mechanical or traumatic fractures. And that could really reduce their mobility. So we have to be on board with managing bone pain, definitely. Renal health, we know that poor kidney function can lead to electrolyte imbalances, dehydration, anemia. It can play a role in fatigue. Renal health is important because there's several different forms of renal dysfunction that can occur in patients with myeloma. They can have cast formation. They can have things like what's called acute tubular necrosis. There can be light chain amyloidosis. There's light chain deposition disease. There's monoclonal gammopathy of renal significance. There's all these kinds of renal pathologies that can occur with the plasma cell disorder. And actually, I think coordination of care with a nephrologist is really important. Some patients might need a renal biopsy to further define their renal dysfunction. I think it's good to have a nephrologist on board when patients are having issues with renal dysfunction. And some centers might even have a nephrologist who specializes in patients with acute renal dysfunction related to plasma cell disorders. And that's a win-win situation for the patient. And also sexual dysfunction. So that it's common. About 70% of our patients report some kind of sexual dysfunction. And this could be anything from low libido, erectile dysfunction, vaginal atrophy. There's a whole host of different symptoms. The causes are multifactorial. I mean, the disease itself, treatment side effects, and the other things we talked about, generalized fatigue, pain, psychological distress. Basically, we do have no problem referring patients to either urology or gynecology for some assistance with these matters. So we do encourage patients to talk about anything with regard to sexual dysfunction with the healthcare team to get proper referrals.
So besides these physical disorders, what are some psychosocial challenges that patients living with myeloma face, and how can nurses help provide support?
I think that there are high levels of psychosocial distress in patients with myeloma. And this can include anxiety. It can include depression. They are always navigating the uncertainty of the relapsing nature of this disease. They know that it has a characteristic pattern of remission, relapse. I mean, they've been online as well too. I think that also coping with chronic pain and fatigue is very challenging for them. And also managing the financial burdens and the diminished quality of life is a concern. So how can nurses provide supportive care in this regard? I think that, again, the communication, the openness, the ability to talk about this. We don't know what's going on with a patient unless they tell us. I mean, we can ask questions, but we have to listen. And I think nurses also have a good rapport with the caregivers. So not only are we listening to the patient themselves, who sometimes doesn't want to reveal things. The practice is too busy. I know that Anne is busy or Lenise is busy. I don't want to burden her with my problems. But the caregiver will come out and say, well, he or she says they're feeling fine, but I want to tell you that he or she is having issues with such and such, feeling more depressed lately, feeling more pain or whatever. So I think that is really important to get that communication out there. And then appropriate referrals, maybe a social worker can help with some financial assistance or maybe some medication to get them through anxiety or depression, even on a short-term basis. I do need to point out that patients need to understand that it's okay to need help. It doesn't mean you're going to be on these medications forever, but sometimes a short-term assistance can help you get through the hump of these challenges, these road bumps. And even with the financial burdens, the social worker can sometimes help with some resources to assist with whatever they may need from a financial perspective. I think that's important to realize as well.
Exactly. So many people want to help other people when other people are sick, but they don't want to accept help for themselves when they're sick because they don't want to be a burden. So, Anne, you've mentioned multiple times that this is an incurable malignancy. Can you talk a little bit about how survivorship has changed with new advances in science and treatment?
It's been amazing. The science, the research, the treatments, the FDA approvals. I mean, for myeloma, it's just been totally, totally admirable. Survivorship has improved dramatically. When we think about a 5-year survival, and if you think back to like the year 2000 to 2004, let's take the first few years of the new century, right? The 5-year survival was about 38%. If you then jump to 2015 to 2019, which is still significant years ago, it's about 7+ years ago, right? It has doubled. So we're talking about anywhere, depending on what statistics you look at, it's anywhere from 60 to 80% 5-year survival. So that's an amazing improvement. And the disease is increasingly managed as a chronic condition rather than a diagnosis with an immediate terminal-like outcome. Particularly with earlier, more effective and sustained treatment options, we can make this disease a very chronic, long-term, livable condition. I want to make sure that patients are aware that this is not a death sentence, right? This is something that patients can live with for the long term. And I always kind of tell patients, I've heard nurses say this too, because they look online and they see that it's an incurable disease. And I always tell patients, and frequently a lot of our patients are either diabetic or know someone who has diabetes. And I always say to them, or the nurses will say to them, well, diabetes is not really curable, right? We're giving you medication every day and we're monitoring you for the rest of your life. Try to think of it like that, like a condition where we just monitor you for the rest of your life. You can live with it for the rest of your life. You can live very well with it, as long as you're compliant with labs, the intermittent assessments that are required. So I think that survivorship has improved dramatically with this disease.
As a long-term heme and transplant nurse, those numbers are astounding to hear and so exciting.
It's really amazing. And I think I might have mentioned this in a previous presentation, but since the year 2000, myeloma as a disease entity has had one of the highest rates of new FDA approvals, whether single agent or combination therapies, than mostly any other malignancy. So in the last 20 plus years, it has been amazing, the advancements in the treatments for myeloma and the efficacy of these treatments, really making patients live so much longer with this disease.
That is so exciting. And I'm going to give a plug for our pharmacy colleagues, because with all of these new treatments coming out, it is impossible to keep track of them. So your pharmacist is your friend.
Yes. Oh, absolutely. I don't even know how general oncologists keep up with all of this, because it's not only myeloma that has a lot of advancements, I'm sure, and I know that all the other heme malignancies and the solid tumor cancers, the world of oncology is exploding with new treatment options. So to keep up with this is very challenging.
So just a few more questions for you. What are some common misconceptions about people surviving with multiple myeloma?
Some of the misconceptions are, and this is something that could be seen if patients or caregivers are kind of surfing the web. It's not a death sentence. It's definitely not a death sentence. We can manage this disease very appropriately, very effectively, and patients can live a very long time with myeloma. I think one of the other misconceptions is that all patients have the same prognosis. So if you're in the waiting room and you have myeloma and you're talking to your neighbor who's sitting next to you who has myeloma, and you're kind of, comparing things, it's not always a good comparison head to head. The disease varies depending on the patient's age, their overall health, their specific pathology of their tumor cells. So everybody's disease is different. And that's always sort of sometimes challenging as well, when patients will say, well, I know somebody that I met, who has an M spike of whatever, and they're not getting treated, but my M spike is lower and I'm getting treated. Everybody's disease is different. And you have to take the whole picture into consideration. And another kind of misconception is that patients will say, well, once I relapse, I don't think there's any more treatment options for me. And they might even say this after having only received 2 or 3 lines of therapy. And I have to really remind them that there are numerous treatment options, and there's still more active research ongoing right now that will definitely lead to more FDA approvals. So there are definitely always something we can do. And also, myeloma doesn't require usually long hospital stays, and people can still live a very productive life. So those are the things that I think that should be known about the disease.
What's something else about this topic that's not often discussed, but you wish people knew more about?
Survivorship in myeloma begins at diagnosis, not just after treatment. And I think that because it is managed as a chronic, often relapsing disease, it does require lifelong evolving care. Patients should realize that they will know us for the rest of their lives. We will know everything about you. I always tell them, I will know everything about your hobbies, your children, your grandchildren, what you love to do on the weekends. It's just very important that that point is made right at diagnosis, not just after so many lines of treatment. That it's very important that we are definitely going to follow these patients throughout their journey.
Is there some additional training or education that oncology nurses need to stay current on this topic?
I think oncology nurses, they are very good at keeping up with their educational requirements. I think they should focus on long-term management of chronic disease rather than just acute treatment. I think especially new oncology nurses are always focusing on disease overview, which is appropriate, and the side effect profiles of the treatments that patients are getting, but they should also include some long-term management criteria. And I think that things like management of long-term side effects, monitoring for secondary malignancies, and of course, navigating that psychosocial impact of a long-term cancer diagnosis. And I am going to say that there are a lot of programs in cancer survivorship that can be accessed. The ONS has a wonderful survivorship library So if you want to actually go online and you can plug in ONS Survivorship Library, there is really a plethora of resources that can help nurses get some education, which will focus on long-term management of these malignancies.
I think that's a really good point, because if I think of an inpatient nurse or an infusion nurse that have more of a intermittent interaction, or their interaction with them is more of a activity rather than that long-term relationship that a clinical nurse might have with the team, those nurses having that understanding of the long-term nature of this disease is very important.
Very important. I think, and there's so many resources to get this information now, because survivorship, because we're actually helping patients live so much longer with their cancer diagnoses, that there are now so many survivorship protocols and programs in place, which is great. So to read up about them is easy, and to find out what the important things are for a specific disease is also, it's out there. So it's easy to access. I think nurses should be aware of the long-term management strategies for these diseases.
So you mentioned ONS's Learning Library on Survivorship. What are some additional resources for patients and providers who want to learn more?
I think the foundations. I always mention the foundations for myeloma, the IMF, the MMRF, Blood Cancer United. They have a large assortment of educational materials, webinars, comprehensive toolkits, and actually for healthcare people and for patients and caregivers. So I think usually if you go onto these websites, you have to click like, I'm a healthcare provider or nurse or whatever, or I'm a patient/caregiver. And that kind of will focus on appropriate tools. Those are the three I recommend for myeloma, but I'm sure there are more out there. So IMF, MMRF, Blood Cancer United, of course, the ONS, the ACS. There's so many out there. I bet if you just plug in like to Google long-term survivorship for cancer patients, you would probably get pages and pages of possible areas to look for information.
And those are the same ones that our patients are finding. So good to have the ones that you recommend that we can then gear them towards for what we know is reputable too.
Absolutely. You want to go to the reputable websites, because unfortunately, there's a lot of information on the web that is not scientifically based. And because really anybody can put anything on the web. So I always try to gear patients to these reputable standard websites so they get the good information.
And it has been such a pleasure talking with you over these last 3 episodes and learning so much more about multiple myeloma and how far it's come over this time. Do you have any final comments for us?
I have enjoyed these podcasts tremendously, and I hope we get to educate a lot of nurses out there and other healthcare providers. I think we're living now in an era where patients are living so much longer and really fuller lives with myeloma. They're doing so well. It's great that patients are living longer. They have good quality of life. We want to kind of sustain that. I think there are new discoveries being made in myeloma treatments all the time, and that will even lead to better statistics for 5-year survival. And who knows, maybe there's a cure on the horizon. I'm always hopeful for that. Despite that, I think patients can live a very long, productive life, a very full life with this disease, as long as they keep in touch with their providers and just keep in touch with us, and we can see what's going on with their disease before they get sick, if that happens.
That was a wonderful closure to that. Thank you so much.
You're very welcome. It's been my pleasure.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.